All right, let's do this. Today, we are stepping right into the hot seat for a classic general surgery viva on vascular emergencies. Look, the goal here isn't just about spitting back facts from a textbook. It's about showing your examiner that you have a structured, confident approach, that you're a safe and competent surgeon. Let's get started. Okay, picture it. The clock is ticking, the examiner drops this case on you. This opener, it's designed to see how you handle pressure, to test your systematic approach right from the get-go. Your very first words are going to set the tone for this whole station. So you take a breath and you start with the absolute fundamentals. So what's the first thing out of your mouth? You're going to say, I would start by taking a thorough but focused history. That statement right there, it's gold. It tells the examiner you're safe, you're organized, and you're not going to jump to any crazy conclusions. This is where you start building your case. I'd tell them I'm going to analyze the pain using a structured approach. I'd ask about the onset. Was it hyperacute, like someone just flipped a switch off in his leg? I'd want to know the exact site. Is it radiating? How bad is it? And is it getting worse? But here's the kicker. I'd ask about associated symptoms. Any numbness? Any weakness? Is the leg cold? Every single answer is a piece of the puzzle, helping you narrow down what's going on. Okay, next up, you have to specifically hunt for the big vascular risk factors. A history of atrial fibrillation? That's a massive red flag for an embolism. Smoking or diabetes? That points you towards underlying arterial disease. Finding these things quickly shows you're already thinking about the why and connecting the dots. Once you've got that history locked down, you confidently tell the examiner, I would now like to perform a focused clinical examination of both lower limbs, making sure the patient is appropriately exposed from the waist down. This is where you go hunting for the physical signs that are going to back up your suspicions. This right here, this is your treasure map for the examination. You have to know this anatomy cold. It's absolutely non-negotiable. As you're examining, you're mentally tracing this path, thinking about the pulses you can feel, the femoral, the popliteal, the dorsalis pedis, the posterior tibial. The exact point where you lose the pulse, that gives you a huge clue about where the blockage is. So my exam starts with just looking, inspection. I'm searching for those signs. Is the leg pale or maybe mottled and patchy? Are there chronic changes like no hair or super shiny skin that tell me this has been a problem for a while? But the most important step here, the one you can never forget, is to always compare it to the other leg. The good leg is your baseline. For palpation, you've got to show you know the moves, even if you're just describing them. I talk them through how I'd feel for that popliteal artery, which, let's be honest, can be a real pain to find. I'd say I'd flex the knee to relax the muscles, put my thumbs on the tibial tuberosity, and then press my fingers deep into the fossa. Describing this two-handed technique shows you've actually done this, you haven't just read about it in a book. After checking the pulses, I'd say I need some hard data. You can't just say a pulse feels weak. That's where the ankle brachial pressure index, or ABPI, comes in. It's a simple, non-invasive test that gives you a number, a crucial, quantifiable measure of just how much blood is actually getting down to that limb. And interpreting that number is everything. For our guy with that sudden, awful pain, we'd be expecting a really low ABPI, probably somewhere south of 0.5. This number turns a subjective complaint into cold, hard evidence of severe disease, and that's something you can act on. Now here's a classic trap the examiners love to set. What if you get a really high ABPI, something over 1.2? You've got to be ready for that. I tell the examiner that this is likely due to calcified, rock-hard arteries, something you see a lot in diabetics, and that the clinical picture of a dying limb trumps this misleading number. That shows real clinical judgment. Okay, so you've gathered all your evidence from the history and the exam. Now it's time to put it all together. I'd state to the examiner, based on my findings, my leading diagnosis is acute limb ischemia. The very next step is to get urgent investigations to prove it and start planning our attack. So what am I ordering? I'd break it down into bedside, bloods, and imaging. Bedside, an ECG right away to look for AFib. For bloods, I need a full blood count, kidney function, a coag screen, and a group and save. But the real game changer here is the imaging. A duplex ultrasound is a fantastic first-line test. It's quick, and it can confirm there's no flow. But the gold standard, the one we need for surgical planning, is a CT angiogram. That's what's going to give us a detailed map of the arteries and pinpoint the exact location of the blockage. So at this point, you can state your diagnosis with total confidence. You look at the examiner and say, my working diagnosis is acute limb ischemia. It's sudden, the blood supply is cut off, and the limb is in danger. You've clearly identified this as a time-critical, surgical emergency. You know what's coming next, right? The examiner's going to ask, well, what's causing it? And really, it boils down to two main suspects: an embolism, usually a clot that flew down from the heart, or an in situ thrombosis, where a clot forms right on top of a diseased artery. Given how sudden our patient's pain was, you'd lean towards an embolism, which is the #1 cause of ALI. All right, this is the moment of truth. This is probably the most important part of the entire Viva. You figured it out. Now what are you going to do about it? The examiner needs to see a clear, safe, and immediate plan. I'd structure my answer starting with the first things I do and then move on to the definitive treatments. My immediate management is all about resuscitation and escalation. High-flow oxygen, get some big IV lines in, and give good pain relief. Then I'd immediately start the patient on an IV heparin infusion. And absolutely critically, I'd make an urgent phone call to the on-call vascular surgeon. The severity of the situation, which we can gauge using these classic 6Ps, tells us how fast we have to move. The moment you see paresthesia or paralysis, any neurological change, that limb is immediately threatened. We have maybe 4 to 6 hours to restore blood flow before that damage is permanent.
Okay, this brings us to the definitive treatment options, nailing those final questions. The right answer really depends on how threatened the limb is and what your hospital can do. For a limb that's still viable, maybe just marginally threatened with no nerve issues, you might have time for catheter-directed thrombolysis, using clot-busting drugs. But if that limb is threatened with any sensory or motor loss, the answer is urgent surgery, no question. We're talking an embolectomy or a bypass graft.
I would really hammer this point home, because everything, and I mean everything in your decision-making, comes down to the neurological status of that limb. If there's any deficit, time is tissue. This immediately pushes you away from slower options like thrombolysis and straight towards the operating room for a procedure like a femoral embolectomy with a Fogarty catheter. And you have to be prepared to mention the worst-case scenario. If the limb is totally dead, with irreversible changes, the only safe answer is a primary amputation. And here's one last pearl of wisdom for the examiner, a little tip that just screams good clinical practice. I'd explicitly state that my physical exam always begins on the good limb. This isn't just a random habit. It establishes your baseline. It tells you what that patient's normal pulses feel like. And this applies to post-op care too. You're always checking both legs to make sure your repair worked and nothing new has happened. And there you have it. By following that logical, structured path, you've taken a simple complaint of leg pain and you've built a complete, safe, and defensible clinical case from history all the way to management. You've shown you have the knowledge, you're safe, and you've got sharp clinical instincts. The only question left is, are you ready for the next one?